Dear student, I am Dr. Prakash Mungli, Professor of Biochemistry. So in this lecture, I will be going over disorders of aromatic amino acid metabolism, particularly a disease called tyrosinemia. Let's get into details on tyrosinemia. There are three types of tyrosinemia that are known, which are hereditary tyrosinemia, which can be classified into hereditary tyrosinemia type 1, hereditary tyrosinemia type 2 and hereditary tyrosinemia type 3. Now the hereditary tyrosinemia type 2 is also referred as oculocutaneous tyrosinemia, sometimes which is referred as Ritchner-Hanert syndrome. Hereditary tyrosinemia type 3 is known as transient tyrosinemia, and hereditary tyrosinemia type 1 is called as hepatorenal tyrosinemia, also referred as tyrosinosis. Out of these three hereditary tyrosinemia, the most severe form of tyrosinemia is hereditary tyrosinemia type 1, which is a hepatorenal syndrome or tyrosinosis. Now here is the pathway that is showing conversion of phenylalanine all the way into fumarate and acetoacetate. So as the phenylalanine is converted into tyrosine and tyrosine is all converted all the way into fumarate and acetoacetate, several enzymes are coming up here. And that is phenylalanine hydroxylase enzyme. We have seen that deficiency of this enzyme causes different types of phenylketonuria. Conversion of tyrosine into 4-hydroxyphenylpyruvate, it is done by tyrosine aminotransferase. Deficiency of this enzyme will cause hereditary tyrosinemia type 2. 4-hydroxyphenylpyruvate is converted to 𝐒𝐲𝐵𝐺𝐼𝑛𝐻 done by 4-hydroxyphenylpyruvate dioxygenase, and the deficiency of this enzyme will give rise to hereditary tyrosinemia type 3. And the drug called nitisinone is going to inhibit this particular enzyme in the step. 4-hydroxyphenylpyruvate dioxygenase is inhibited by nitisinone. Nitisinone. This is the drug that we use in the treatment of tyrosinemia, especially type 1 tyrosinemia. And then the conversion of 𝐒𝐲𝐵𝐺𝐼𝑛𝐻 into melloyl acetoacetate is done by 𝐒𝐲𝐵𝐻 oxidase enzyme. Deficiency of this enzyme will give rise to alkaptonuria. We are going to see that disease later separately. And then the melloyl acetoacetate is converted into fumaryl acetoacetate done by melloyl acetoacetate isomerase. And lastly, fumaryl acetoacetate is converted to fumarate plus acetoacetate by fumaryl acetoacetate hydrolase enzyme. Deficiency of this enzyme will give rise to hereditary tyrosinemia type 1, which is also called as tyrosinosis or hepatorenal syndrome. So these are all the reactions in the conversion of phenylalanine all the way into fumarate and acetoacetate and some of the disorders along the pathway. Now let's move on to see hereditary tyrosinemia type 2, which is also called as oculocutaneous tyrosinemia or Ritchner-Hanert syndrome. Defect here is in the tyrosine aminotransferase enzyme, which is coded by a gene TAT for tyrosine aminotransaminase. Clinical manifestation includes lesions of the eye and skin. That is why the name of the disease is oculocutaneous. And also there can be involvement of neurological system. Neurological issues can be seen here. Painful corneal erosions, plaques, inflammation like keratosis of the palms of surface and mental retardation. These are some of the signs that you see in hereditary tyrosinemia type 2. And inflammation of the eyes are because of crystallization of tyrosine leading to inflammatory process there. Patients treated with low tyrosine and low phenylalanine diet, so generally improves the clinical manifestation. Coming to hereditary tyrosinemia type 3, which is also called as transient tyrosinemia because of deficiency of 4-hydroxyphenylpyruvate dioxygenase enzyme coded by HPD gene. Now, it is frequently observed in newborn infants, especially those who are born prematurely. For the most part, the condition appears benign. Dietary restriction of proteins returns plasma tyrosine levels to normal. Because 4-hydroxyphenylpyruvate dioxygenase enzyme requires ascorbate, so ascorbate supplementation leads to a decrease in the circulating levels of tyrosine. So that is one of the treatment aspect that is tried in hereditary tyrosinemia type 3, and that is ascorbate supplementation. Coming to hereditary tyrosinemia type 1, which is also called as hepatorenal tyrosinemia or tyrosinosis. Deficiency of an enzyme called fumarylacetoacetate hydrolase. It leads to buildup of fumarylacetoacetate, and this fumarylacetoacetate, furthermore, it will lead to buildup of malylacetoacetate. And fumarylacetoacetate and malylacetoacetate, these two are DNA alkylating agents, and they can cause DNA damage and may predispose tissues to tumor formation. Not only that, patients with the tyrosinemia will suffer from liver damage and kidney damage, and patients may go into liver failure and kidney failure. The reason for that is fumarylacetoacetate and malylacetoacetate, they can be converted into succinylacetone, and this succinylacetone, it's a mitochondrial toxin, and also succinylacetone, it is going to inhibit heme synthesis. And because of these reasons, succinylacetone elevation in hereditary tyrosinemia type 1 may lead to liver failure, kidney failure, porphyria-like signs and symptoms, which involves neurological signs. So that is the reason why tyrosinemia type 1 patients, they suffer from severe liver damage, kidney damage, they are prone to DNA damage and tumor formation, and also having a neurological issue. And one of the characteristic finding that you see in tyrosinemia type 1 is a characteristic body odor. Body fluids will have a cabbage-like body odor, and that's because of excess levels of fumarylacetoacetate and malylacetoacetate in the blood appearing in the urine. Now, the treatment for tyrosinemia type 1 is use of drug nitisinone. This nitisinone drug is also used in the treatment of alkaptonuria. The mechanism is nitisinone, it is going to inhibit an upstream enzyme called 4-hydroxyphenylpyruvate dioxygenase. Let me show you that. So in this pathway, as you see, so tyrosinemia type 1 is because of defect or deficiency in fumarylacetoacetate hydrolase enzyme. That leads to elevation of fumarylacetoacetate, and this fumarylacetoacetate leads to elevation of malylacetoacetate. Both fumarylacetoacetate and malylacetoacetate will be converted into succinylacetone, and this succinylacetone will lead to liver and kidney damage, and that's how a liver failure or kidney failure can happen. And also succinylacetone is going to inhibit heme synthesis, leading to accumulation of porphyrin molecules, and these porphyrin molecules may lead to neurological issues, photosensitivity and all that. As such, fumarylacetoacetate and malylacetoacetate, they will cause DNA damage and lead to different tumor formation. So all these signs are decreased by use of a drug called nitisinone, because this nitisinone is going to inhibit enzyme 4-hydroxyphenylpyruvate dioxygenase enzyme. So by inhibiting this enzyme, it is not allowing 4-hydroxyphenylpyruvate to go into homogentisate, and homogentisate further into malylacetoacetate and fumarylacetoacetate. So basically, use of this drug will decrease accumulation of malylacetoacetate and fumarylacetoacetate, thereby decrease the DNA alkylation process, tumor formation, liver damage, kidney damage, because succinylacetone, which is a derivative of fumarylacetoacetate and malylacetoacetate, so it's a mitochondrial toxin, so that can be prevented. Now, so that is why drug nitisinone is used as a first line of treatment, and nitisinone must be used in conjunction with the diet restriction of amino acids, especially tyrosine and phenylalanine. Treatment with nitisinone and dietary management should begin as soon as possible after diagnosis is confirmed. And also therapeutic use of 2-nitro-4-trifluoromethyl-benzoyl cyclohexanodione, which is written as NTBC, in tyrosinemia is not well proven, but children with this disease who receives NTBC prior to age 2 years have less than 5 years risk of developing hepatocarcinoma. And this NTBC also inhibits 4-hydroxyphenylpyruvate dioxygenase enzyme, as I have shown in the previous figure. So that's about tyrosinemia, different types of tyrosinemias which are associated with defect in the metabolism of tyrosine. In fact, defect in the catabolism of tyrosine. Thank you.